Hi everyone. Today I'm going to go over some information, advanced practice nursing, the nurse-patient relationship, and general ethical concerns. So it starts out with virtue ethics, the characteristics of good advanced practice nurses. Value ethics is what we'll start with. And we're going to talk about some common issues faced by advanced practice nurses, regardless of what your practice is or your specialty concentration is. And we're going to also discuss some of the relevance to the work of nurse leaders and nurse educators, who are people who provide advice and support for advanced practice nurses. So value ethics want to contribute to the welfare of others. So there's many people who are attracted to the nursing profession because they do see it as a practice that contributes to the good of all individuals, as well as the good of society and a bigger goal. It's true for the undergraduate programs as far as nursing and also advanced practice nurses. So the desire to contribute to the welfare of others is often considered a virtue, okay? So a virtue as opposed to the desire to hurt somebody, which we would consider a vice. So when we talk about good, we're talking about good is kind of synonymous in this case here with ethical. Virtue ethics in healthcare practice is essentially the idea that a person can cultivate certain characteristics or virtues, certain virtues that will allow him or her or predispose them to good actions or ethical actions. You all know, like, your code of ethics and that all, if you look at those, they talk about just good behaviors, virtuous behaviors. View of contemporary moral philosophers, basically that philosophers' idea is that a good or a virtuous person is someone who possesses practical wisdom or prudence. So it's just a definition of good, which is just kind of a difficult concept to actually define. So criticisms of virtue ethics, well, what I just said, there's really no universal definition of what is virtuous. So with that being said, it includes observations that we see what is virtuous in one situation or for one person or for one culture may not be considered virtuous for another. So again, there's really no stable definition for the idea of a virtuous person, nor is there really a list of virtues or characteristics that a person must possess to be characterized as virtuous. So, factors that interfere with ethical nursing action. So I don't really have any of them written down here. So some virtues of nursing, we could see where nursing is understood to have the requirement or be required to develop certain characteristics, which are synonymous to providing good nursing care to patients. And factors that could interfere with those characteristics of being good and ethical are divided into two categories: agent-related and environmental. Agent-related would be barriers that include things like just openness for reflection. Like, so for example, the ability to make a mistake and learn from them. That's what we would consider a good person would admit to their mistakes. a virtuous person would admit to their mistakes and take the consequence for it versus lying about it, which could possibly potentially be harmful for somebody else. Personal or emotional issues that we allow to interfere with our performance. I'm not focused today. I just can't think today. I'm just too stressed out about something, including energy levels, feeling powerless. You just don't have any power at work, inability to connect with a patient, possibly. It's just somebody that you just don't agree with their lifestyle, or just somebody that you just don't like or have had some type of an altercation before. Maybe some fear of disapproval, either by a peer or a patient or something. Maybe we take care of a patient and we disapprove of their choice, so we treat them differently based on a choice that they made. They're in because they have lung cancer and they smoked their whole life, and sometimes it's difficult to be maybe ethical or virtuous or have good characteristics while caring for them. Time of the day could be something else as well. Complexity of preceding workload or decisions. It's the end of the day. It's 11 o'clock at night. It's 3 a.m. I just can't do this, and so it affects decisions. Even level of knowledge related to the issue. Maybe there's a level of knowledge that's not there, and the provider continues to care for the patient without seeking help. Another thing we could add to this, and we'll talk about our biases. So, we have certain biases that we may or may not know about, but these can all be factors, agent-related factors that interfere with nursing action that can be ethical. And there's also environmental factors, which are pretty similar. Pressures from peers, supervisors, just demands, just constant demands in the workplace, too many patients, too many complex patients, not enough time, just maybe some institutional conditions, economic conditions, time constraints, resource constraints. We've all kind of worked under those. Conflict of interest in regard to where the philosophy of the care could be coming from. Just many things, and those are just the examples that I can come up with. So, virtues of nursing, strategies for nurturing virtues. So, nursing practice and the fulfillment of nursing goals can be understood as requiring the development for certain characteristics. These characteristics that can be helpful to provide good nursing care to patients, like I said, which are outlined in the code of ethics. And as far as nursing education, the nursing curriculum should include strategies for nurturing these characteristics or good characteristics for nurses to understand. And they do, and some things that are included in these characteristics of good nurses are, would all probably agree, compassion, integrity and honesty, being patient and tolerant, just perseverance and hardworking, and there's just many, many more characteristics that can be put on a list. Cognitive biases. So we could have some biases, and biases are inbuilt mechanisms of human thinking that we may have thought to have served a purpose, but really can be problematic, especially in today's society, and in the 21st century. They're mistakes that our mind makes during information processing. And sometimes a bias can cause us to make shortcuts in decision making. They can lead to errors in information. gathering. When we gather information, they could make errors in judgment. So these are important to kind of understand and think about what our biases are. And two different types of bias is implicit bias, which results from an association of which we are not consciously aware and which predisposes us to a negative evaluation of someone based on their characteristics, for example, their race or their gender, or maybe a physical difference, a behavioral difference. And there's plenty of evidence that contributes to and supports that these implicit biases contribute to healthcare disparities. The next one is confirmation bias. And confirmation biases are the result of human tendencies to just latch onto information that confirms strongly held beliefs and discards information that doesn't fit with our beliefs. So an example of this would be like a healthcare provider who may disseminate maybe some unsubstantiated claims like the COVID vaccine, for example, talking about why the COVID vaccine is dangerous and telling patients that they should not get the COVID vaccine, and could just be based on misinformation or just personal opinions. The next is informed consent. What is informed consent? The principle of autonomy underlies the idea of informed consent. So autonomy, having the ability to make your decisions. We, as humans, have the ability to reason, to decide, to act, and a person has the right to make their own decisions concerning their health care. And they should be able to make these decisions based on health care, to make their decisions related to health care, and they should be free from any biases or any interference from anybody else, at least as far as personal decision making is concerned. Patients have a right to accept or refuse healthcare treatments. Healthcare providers have responsibilities to facilitate persons' understanding. So we do know that past cultural or educational or any religious or family influences make absolutely autonomous decision-making impossible. We're just all subject to unconscious pressures and that cause us to act in certain ways, but the patients still have moral and ethical rights to accept or refuse healthcare treatments, regardless of what the risk is, given the fact that they actually possess the capacity to make a decision and they have an adequate understanding of the risk if they refuse, and they should know risks of refusal and potential benefits of the treatment. So that is informed consent. That is information that they should have, and they still have the right to make the decision if they know those main things. And then the healthcare providers have responsibilities to facilitate persons' understanding, make sure they have received the necessary information, and that they understand that information. So there's 3 different types of consent. One is implicit consent. So people can give 3 types of consent, or verbal consent or written consent. So these types of consent are given permitting healthcare professionals to evaluate the patient and to act on their health needs. When a patient's unable to consent, then we know that an informed proxy makes the decision on the patient's behalf with the patient's interests and values in mind, if they know about them. And we call that, with that proxy, we call that substituted judgment. We would assume that there are general things that a reasonable person would want, even if we don't know all the information. For example, they don't want suffering, they don't want pain, they want to be made comfortable. If there's a possibility to restore and maintain their physical and mental integrity, somebody would want that, if that was a possibility. So these are things that we just assume, even as a proxy or healthcare provider, that somebody would want that. So when we talk about informed consent, a definition that we could have is that it's the process of interaction between a healthcare provider and a person, so the advanced practice nurse and a patient, in which necessary information is exchanged and the person has an appropriate level of understanding, which will enable that person to make a decision about acceptable and appropriate care, appropriate treatments, intervention, and of course, this is in light of their pre-existing values, their beliefs, their lifestyle. So let's talk about implicit consent. So just when we present to the healthcare setting, like our doctor's office, or we go to a hospital in search of some type of assistance for our health needs, we are implicitly consenting at minimum to be evaluated for those needs. If not, then we don't need to be going. If it's an inpatient or an institutional setting, such as a hospital, then the person might sign a form giving consent for certain routine evaluations. However, those forms don't detail anything specifics. It's just a general form of consent, which is just really implicit. Think about really the people who typically admit persons, and they ask for the signatures. They don't really have medical or nursing knowledge. So generally this type of consent is not usually very informed, and the patients may not really understand what rights they have. The second one being verbal consent. A verbal consent would be somebody that we might need to explain something a little bit more. So for example, sometimes before we're doing an exam and we want to do, for example, a breast exam on a woman. Well, she's coming in for a physical, we would expect that that's in there, but sometimes instead of just assuming that that person is okay with it, we would get a verbal consent and say, is it okay that I do your breast exam at this point, or this is the point that I would do your breast exam, and just for a little verbal consent. It's probably the best one that I can think of. Probably another one, you go to the doctor and they're going to draw blood, and whoever's drawing will say, okay, I'm going to go ahead and draw your blood now. You just get a verbal consent. Yeah, okay, that's fine. Use this arm. Or you don't get a verbal consent. So that's really the main thing with verbal. The third one, the written consent, which is the third type of informed consent, is actual written, and it's intended to protect patients from ethical or legal breaches and make formal their right to all relevant information tailored specially to them. And you're probably familiar with this. You're all experienced nurses, especially practicing in institutional settings. You're familiar that this informed written consent generally relates to invasive medical procedures, or maybe somebody who's participating in a research study. And of course, it requires that a person is able to thoroughly grasp what is intended and is not unduly influenced by anybody else. And they understand that prior to any professional proceeding with any type of invasive procedure. With that being said, with the written consent, when in the case of a proposed invasive procedure or like surgery, the person who's responsible for carrying out or supervising the intervention, the person who's going to be doing the surgery, the person who's going to be putting the central line in, or the invasive procedure, that is the person who is responsible for obtaining the written consent. So this is usually the physician, the advanced practice nurse, if that advanced practice nurse is qualified to perform that procedure. Anesthesia would be responsible for getting their own consent. Okay. The next slide here, continuing with informed consent, we'll talk about ethical problems. Ethical problems, conscience, and personal integrity. So conscience and personal integrity. So conscience is another kind of abstract term, and there's really no consensus on what its meaning is. For the purpose of this lecture, we're going to take the stand that conscience is a set of core moral beliefs that matters most to that person. Okay, that's our conscience. Your conscience is talking to you. Thus, acting against those beliefs is likely to cause harm in terms of a disrupted sense of integrity. Okay, so our conscious or personal integrity, refusal to provide patients with certain information and services. Intentionally not providing patients with the information that they need. And again, a perfect example is COVID vaccines. People being worried about its safety due to the speedy development, their concerns of possible harm, and nurses really needed to educate themselves about the actual development process of the vaccine, because so much information and misinformation was based on information. Let's see. Another thing would be maybe refusing to provide somebody, maybe somebody we're referring to a mental health service. We only, because it's our belief, we only send them the information for a Christian mental health facility. Maybe somebody's neglecting to offer some options that are available for a woman with labor pains, by just encouraging this woman, have an epidural. It's just that it's the best way to go, and just really not offering any other options. So those are some examples of refusing to provide patients with certain information, and that certainly is based on our beliefs. Moral distress on nurses. So we all know what this it feels like. Just the feeling of not being able to give care that's needed, or asked to participate in care that you feel might be wrong or harmful. That can cause moral distress on nurses for sure. Causing some nurses to leave the profession, can cause some nurses to distance themselves from certain patients, like maybe taking care of a child who is from a Jehovah's Witness family, and feeling like that the care can't be completed due to some of the religious beliefs with blood transfusions. It could be just emotional and or ethical conflict, and can cause that. So culturally based communication issues. Okay, so culturally based, there's other issues that can serve as an obstacle to obtaining informed consent, and they're related to culturally based differences, which can also be communication issues, or like a lack of this person's fluency in the language of the country that they're in. Impact of implicit bias and racism, considerations for language difficulties. So in our Western culture, we value autonomy and the ability to make our own decisions, but in many other cultures, these decision-making responsibilities can belong to somebody else, like maybe the head of the household, or the pastor, or the whole family. The whole family has to agree. And so when we try to understand the beliefs and the values of someone from another culture, can be confusing, and it can be a frustrating kind of task, and difficult to separate our beliefs from theirs. So yeah, I think I said everything about that. Difficult patients. We've all encountered patients whom we perceive as difficult in some way. And a difficult patient, by this Wolf and Robinson Smith's definition, say that these are whom nurses perceive consume greater periods of time than their condition suggests. They impede the work of nursing staff with their demands, with their complaints. They become uncooperative. Sometimes it's not necessarily the patient, but it can be the family who is perceived as difficult. As a nurse or a provider, we may experience a dislike for them. Maybe we know why, or we have unknown reasons why we dislike them. Maybe this reminds the nurse of somebody who in her life that they argue with, or maybe the patient is questioning something about what the nurse is doing or the healthcare provider is doing. Maybe the patient's violent or abusive and argumentative. Also, certain patients, we could stigmatize them by their lifestyle, obesity, by their certain diseases that they may have, HIV, COPD. Whatever the reason for the perception here of a difficult patient, we're still responsible as the advanced practice nurse to try to meet these patients' needs. And two strategies frequently used are demonstrating respect for the patient and focusing on the issue at hand. So this includes avoiding labeling the patient, and focusing on the illness and not extraneous type of issues or family issues. Okay, so the last slide, other influences on the informing process, conflicts of interest. And conflicts of interest are pervasive in healthcare practice regarding of what the profession is in healthcare. And this exists anytime there is pressure or temptation to act so the patient's interests not held as primary. Um, the conflict of interest in professional nursing practice can be several types. It could be economic, such as when financial pressures on a clinic or a healthcare institution shift the primary focus off the patient's good, and it's based now on economic reasons, why or why not we're doing some type of an intervention. Interpersonal is another type. It's such that occurs when a battle between providers for control of a situation causes loss of focus on mutual goals. So two providers are fighting over a treatment, and hence the patient may not get the treatment, or they may not get the appropriate treatment. There's also environmental conflicts of interest, when others do not notice that there's a problem, and they put pressures on nurses to go along with whatever the status quo is. Um, so they may not know, somebody else may not know really that there's a problem, and just want the nurses or the caregivers to treat the patient the way that we do others, and there's not an exception with this person. So some examples too, probably one of the biggest examples of conflict of interest in my experience is drug company the drug company reps. And they provide dinner for our local advanced practice nursing association, for the practice. They come to the office, they bring samples of medications and urge us to use them. And many studies have shown and confirmed that drug company gifts absolutely influence prescribing patterns. So that is probably one of the biggest conflicts of interest that I'm familiar with. Okay, that'll be the end of part 1.